Thank you and good morning. Ni hao and good morning. I am so pleased to be here, and I thank the Planning Committee for the opportunity to share with you some information about professional self-regulation in the United States and board certification, but even more for the opportunity to learn from all of you over these 2 days. My comments today, I'm going to talk to you about how professional regulation actually came about 100 years ago, key components of a very complex system, and then board certification in particular. 100 years ago, American medicine was in a mess. The training, the education, and the practice. The gentleman in the middle, Abraham Flexner, completed a report, a study of medical schools that was so scathingly bad that multiple medical schools closed, and people said, we need to have more oversight of medical education. The 4 other men on this slide, the 3 on the right, they said, we're licensed physicians and we're surgeons. And that actually is Dr. William Mayo and his sons, Drs. Charles and Will Mayo, and they were surgeons and they were spectacular. But the gentleman on the left, that's John Brinkley. He was a licensed physician, even though he bought his medical degree and in fact never graduated from medical school. And after he became a doctor, he called himself a surgeon, and for over a decade, injured, maimed, and killed people in his practice. Things were a mess. And what happened was that the public, but also the profession, said, we need to do something about this. And what came out of that was a conversation within the profession and elsewhere about the social compact. If you read about professional self-regulation in the United States, you will see time and again reference to the social compact. 3 parts to it. First, the recognition that physicians have special skills important to society and very rare in society. The second element is that they commit, and we commit as a profession, that we will use those skills first and foremost for patients and society, not in self-interest. And third, there is an agreement between society and the profession. They trust that we will do this, and what they have given the profession is substantial opportunity to self-regulate. And so in the United States, we see a combination of regulation by the state governments, but also professional self-regulation. The collective community is expected to regulate the profession, and I will say there are parallels across nursing and the other health professions as well. Standards are developed, and assessments are developed against those standards. There are required processes, but most of them are voluntary processes, but voluntary processes that have been enabled or empowered by government regulations that recognize the private process. Key components that you will hear about include professional self-regulation of institutions and programs, and that is typically called accreditation. Examples are the Liaison Committee on Medical Education, which accredits medical schools, the ACGME, which we will hear about, the Joint Commission with accreditation of hospitals. And then there's professional self-regulation of the individual, of the physician. And that is done through medical licensure, board certification, and credentialing. And the 2 largest board certification processes in the United States are the American Board of Medical Specialties, with over 850,000 physicians, which until today seemed like a large number to me, but of course, small compared to some of the other numbers here. And the American Osteopathic Association, which certifies osteopathic physicians, and they have about 25,000 physicians that they certify. And then credentialing, which is done at the hospital. Before I go into board certification, let me distinguish it from physician licensure in the United States. Medical licensure in the United States is a government function that is given to our states. The state medical boards give a medical license, which is the basic credential that is mandatory to practice as a physician in the United States. It is undifferentiated. The boards, on the other hand, are private, non-governmental, not-for-profit organizations that count on a very heavy voluntary commitment of physicians. Thousands of physicians participate in setting the standards and assessing physicians against those standards for their individual specialties. It is a differentiated credential. It is not required to practice medicine in any of the states, so it's a voluntary credential. But frankly, hospitals, health systems, and others oftentimes expect the credential, and so it becomes really what is used in many settings. Let's focus now on ABMS board certification. The American Board of Medical Specialties, which I lead, works with our 24 independent, not-for-profit boards to serve the public by improving the quality of health care through setting professional standards. The member boards certify the individual physicians. The ABMS helps establish the framework in which that is done. There are 24 boards, as I said, that certify in 37 specialties and 86 subspecialties. And maybe something we'll talk about later on is that too much fragmentation, and what does that do? These are the boards. They range from the very large internal medicine, with which its subspecialties has over 200,000 diplomates, and the very small colorectal surgery with fewer than 3,000 diplomates. The oldest one is the American Board of Ophthalmology, the youngest one, Medical Genetics and Genomics. All of the boards certify physicians, both MD physicians and osteopathic physicians, if they meet the certification standards. Two of the boards, Medical Genetics and Genomics and Radiology, also certify non-physician professionals. Think of board certification as an initial process and then a continuing process. For initial board certification, the board expects physicians to meet the professionalism, knowledge, skills, and behavior standards set up by the board. And this is most commonly done through successful completion of an ACGME accredited residency or fellowship. So years of training in the specialty to gain. In addition, the boards have other assessments. All boards use a comprehensive, high-stakes examination, written examination, and many boards, particularly the surgical boards, also use oral examination, in some cases standardized patient examinations, review of patient records, and the like. Why has board certification been successful over 100 years? Because it has absolutely been demonstrated that board-certified physicians have improved patient outcomes. This slide just shows a couple of studies that the internal medicine community has done showing improved patient outcomes in heart attack, ulcer, asthma, and other conditions. Now, for the first 50 years of board certification, it was a once-and-done phenomenon. You got your board certification and that was it. But that was insane. After a period of time, people noted that they depended on that board certification status in choosing their doctor or in bringing someone onto their hospital. And it was very problematic if I earned my board certification in neurology 30 years ago. And so there was movement to continuing certification based on studies that show medical knowledge advances. We all know that. Skills can decline. Physicians' ability to self-assess is limited. And it's not that physicians are any different than anyone else in the world. Everybody's ability to self-assess is limited, although sometimes our physician colleagues don't believe that, and patients and credentialers expect it. So in the 1970s, and actually beginning in 1970 with the American Board of Family Medicine, periodic recertification with an exam every 7 to 10 years began. And in the year 2000, the maintenance of certification program began, which is intended to be a more regular, more continuous opportunity for ongoing certification. The ABMS has standards for programs for maintenance of certification, and then the different boards operationalize those standards differently, because what is right for a family physician may be different than a dermatologist, than a neurosurgeon. But all programs have 4 integrated elements: professionalism, the expectation of ongoing learning related to what the physician does, assessment, and participation in quality improvement activities in the physician's practice or in their health system. The boards make a summative conclusion about continuing certification based upon the physician's participation. We're talking about innovation in this session, at this conference. So let me point out to you that one of our standards for programs of MOC is that there be innovation. And 2 of the areas in which most innovation is occurring is, first of all, the assessment, where 12 of our boards are looking at a more continuous, take-it-home, low-stakes sort of examination rather than the high-pressure examination. And then improvement in medical practice, where many of our boards, 21 of 24, participate in a portfolio program that allows physicians to get MOC credit in this area for the most important quality work that they do in interprofessional teams and cross-specialty teams. So that really has enhanced some of the working together of our interprofessional teams. MOC is young, but early studies demonstrate that physicians participating in MOC are improving the care of their patients. In addition, very importantly in our country with the out-of-control healthcare costs, one study showed that physicians have equal outcomes of care, but at reduced cost, which was felt to be related to less referral and less unnecessary testing. Now, it was only $167 per patient, and some people poo-poo that. But for the Medicare population, that adds up to huge numbers. Before I conclude, I wanted to talk for a moment about how a board becomes a board or a specialty becomes a specialty or a subspecialty. And I've highlighted that emergency medicine, family medicine, and medical genetics and genomics are our newest specialties. To evolve a specialty or a new subspecialty, it's important to show that there's a distinct patient population, a body of knowledge and care to fit that patient population, sufficient numbers of programs and trainees and standards to assess against them, and recognition that the recognition of the distinct specialty will improve access, quality, and coordination of care more than it has the potential to increase costs. Addiction medicine is the most recent subspecialty of the within the American Boards of Medical Specialty and is within the American Board of Preventive Medicine. But I thought I would end, because we're very concerned about the general population, with just a few things and a few lessons from the history of the American Board of Family Medicine. One thing is, in general, physicians want their board or their specialty to be certified. In family medicine, it was actually a big fight within the general practice community as to whether they ever wanted this to happen at all. It took 30 years. In 1940 through 1960, some of the early work was done defining the specialty, but there was great consternation within the specialty whether it should occur or not. It did occur, and the second point that I would like to make is that the recognition of family medicine as a specialty is extraordinarily important because most of the time, just the word makes us think narrow and deep, specialized, get smaller. And this helped us all understand that specialties can be comprehensive as well. And that is a comprehensive specialty. I will tell you that family medicine has evolved to be one of our largest boards. It was the first board to require ongoing periodic certification. And it is a board that I believe has increased the stature, the status, and the quality of family physicians in our country in some very important ways. So I will stop there and look forward to our conversation during the discussion.